Hi, this is Ed Levin. I'm director of the Duke Center on Addiction and Behavior Change, part of DIBS, and welcome to our final presentation in our seminar series for the fall 2021 semester. And just to let you know, we're going to be starting right up in January for the spring 2022 semester schedule, and come back and reconvene here. It'll also be Zoom as a way to connect. And on January 19th, we're going to have Linda Perino, who's a longtime leader in the field of drug abuse research, and she's going to, from Wake Forest University, talk to us about the consequences of chronic drug use and her experience over her career. And then importantly, on January 26th, we're going to have a couple of the participants and graduates from TROSA, and Dr. Razvani's online. Dr. Amir Razvani is one of the trustees of that group, but they're going to talk to us about this kind of real life experiences in terms of their experiences of with addiction and recovery from addiction. And then we're going to have a series of talks from people at Duke and people from other institutions. And one thing I wanted to really highlight is this symposium that we're going to have on the marijuana legalization and brain science community impact risk prevention, together with Together for Resilient Youth group, Dr. Wanda Boone, who does a great job in the community combating drug abuse among the youth. And so we're going to be, it is free, but you need to register so we can, have a head count. So just go on the DEBS website and the CABC page on that, and you can register for that symposium. And then for any of this seminars, just drop in, and anybody can participate as you would like. And I'm starting to put together the fall 2022 series. So if anyone would like to present, or if they have a suggestion for someone who they think would be good to hear from, please let me know, edlevin@duke.edu, and just drop me an email, and I'll try my best to get that lined up. So today we have a dual presentation. Dr. Connor O'Neil and Dr. Angela Tunno are going to be presenting their work. Connor earned his PhD at our sister institution down the road here, University of North Carolina at Chapel Hill, and he is involved with the Center of Trauma-Informed Assisted Suicide, Self-Harm, Substance Abuse Treatment and Prevention. So that's all very necessary and essential for making an impact on community health. And then Angela earned her PhD at the University of Kansas and did her clinical psychology internship here at Duke, and is they're both on the faculty in the Psychiatry and Behavioral Sciences Department. And her interests include public policy and advocacy for children, youth, and families, prevention of maltreatment and resiliency factors, and PTSD. So today they're going to speak to us about evidence-based treatment for co-occurring substance use in adolescents and young adults.
Thank you so much for that introduction, Ed. I'm going to go ahead and share my screen to bring up our slides. Great. Can everybody see that? Can you see that, Angela? Can you confirm for me?
I can see it.
Yeah.
Great.
Adjust my screen a bit. And I want to, encourage you all to pull up the chat feature. We're going to make this as interactive as possible within a 1 hour time frame. So I know a lot of you have to log off right at 1. I also want to encourage you all to take care of yourselves during the talk. Turn your camera off, go get something to eat. It's lunchtime. And hopefully we can just share this space and learn together. So we can go to the next slide. So thank you for the wonderful introduction, Dr. Levin. We're also from the Duke Center for Adolescent and Young Adult Substance Use Treatment. Connor is going to talk a lot about what we do as a part of this team, but wanted to give a shout out to our team. And also the website is here at the bottom if you're interested in learning more and as a potential referral source. We can go next slide. Yeah, thanks, Connor. So today we're going to start off with just a little bit of time on statistics and trends, both what we're seeing nationally and some anecdotal data that we also are seeing within our CAS team. I'm going to go into a little bit about the interrelation of substance use and traumatic stress. And that's really my area of focus, both research and clinical work and training. Then we're going to talk about screening and assessment for substance use, focus in on the emphasis on co-occurring presentations. And then Connor's going to go into a lot more about our CAST program, how we approach treatment and services and what we offer. But before we get started, I warned you all that the chat was going to be something we'd use. So I really want to encourage interaction just so that we know what you all are interested in too. When you came to this presentation today, and thank you all for taking the time, I know you're very busy, what are some things or some questions that come to mind that you would like to focus on when talking about substance use treatment for youth and young adults for that population? What are some questions? And you can either put it in the chat or even come off mute. And you can percolate on it for a little bit if you want to. I wonder, as we might go forward, Connor, and as we're talking, putting some things in there about, I'm really interested in how to screen for this or how to talk to parents about this or the family approach, whatever comes to mind.
I had a question. This is Ed.
Yeah.
In terms of, I'm a former adolescent, as we all are. And so the transition from experimenting to abuse, how do you kind of determine who might just mess around and mess up a little bit and then go on to be quite well, and people who take a downward spiral? I mean, can you tell that at an early stage and intervene? I mean, you may not want to intervene with every single person who tries something, but if you can have some way of seeing who's going to be headed in a bad way, then select those people.
Yeah. We can definitely focus on that in part of our section of when do you know it's a problem? When do you know it's time to intervene? Yeah, that's a great, we'll talk about that throughout, for sure.
And my name's Jeff George. I clinically am seeing an awful lot of adolescents with early onset cannabis use disorder and thought disorders, or at least heading in that direction, and would love to hear you talk about that as well.
Wonderful. And we'll definitely incorporate that. Connor, I'm thinking of some of the content that you have.
Absolutely. Okay. So I know, there is just a wealth of expertise in our Zoom room today. And so I'm just going to briefly just cover a little bit of statistics and trends. And then I'd rather really talk a little bit more about the anecdotal trends that we're seeing within our clinic, what we're treating and what we're noticing in our youth. So coming from the Monitoring the Future data, really the marijuana use seems to have been relatively steady over these last several years. And you can see with, coming in around a third of folks in the high school age range having used marijuana in the past year, significantly less for eighth graders, but hovering around that 10%. And as we look at alcohol, similar in that going back, a decade or so, there was a more precipitous decline in alcohol use in the past year, and that's really started it's started to level off with much higher than cannabis use. But I'll say, and I was talking, we were talking with Ed about this earlier, in our clinic, the presenting problems that come to us, it tends to be, as Jeff was just mentioning, it tends to be more of the cannabis use. That seems to be the presenting problems that we're seeing within our clinic in terms of questions for referral. But as you can see, alcohol use prevalence is high, and that speaks a little bit more to what Ed was talking about here in terms of experimentation. When is it, do we want to be intervening with half of 12th graders that have used alcohol, and what point do we want to intervene, and how do we know? I think the big question is, what have these trends looked like with COVID-19, and how have things changed as a result of the pandemic? And some of the data that's recently come out was looking at, again, it was the same monitoring the future self-report ratings by youth, but it was looking at post-pandemic onset. So these data came from mid-July to mid-August of 2020. And importantly, there was a significant reduction in self-reported availability of alcohol and cannabis. And that's the good news, is that the availability went down. The not so good news is that this did not translate to reductions or statistically significant reductions in use, both for marijuana or alcohol. So marijuana use in the past 30 days pre-pandemic was around 23%, and during the pandemic, it remained at 20%, so it held relatively steady. The same was said for binge drinking in the past 2 weeks of alcohol. This is among 12th graders, 17% pre-pandemic, 13% during the pandemic. And so the important takeaway here is that while social distancing, there was restricted opportunities for youth to be engaging with their peers, there is restricted access to an opportunity for use of substances, the rates remained relatively stable. And that really speaks to how we should be thinking about substance use in youth and how we should be approaching the treatment models. And that restricting access is just part of it. But there's other parts that we need to be attending to. And we'll talk a little bit more about how we approach that in our clinic. Some considerations around COVID-19 and substance use. You know, as I'm sure you all have, this is a question we've probably been asked if you're working in this field, and it requires certainly a great deal of attention and thought. The stressors can certainly be more pronounced with the social isolation, potential financial difficulties, being stuck in space with stressors like family members. A lot of the work with our clinic and with youth and young adults is family focused. And when there are stressors within the family and there can't be those outlets outside of the home, it can exacerbate things. There was a lack of structure and a lack of access to alternative pro-social activities that can be used as replacements for substance use and reduce the frequency of use. There has also been some difficulties accessing treatment, although at the same time, the move to virtual has increased access to some, but not necessarily for the more acute and high intense, more severe needs of substance use among youth. And the move to virtual work has also created more of, it's exacerbated disparities for some, but of course created more access for others, but does still, you know, it requires, you know, some understanding and attention on how this virtual work is affecting different groups across the country. And from a medical perspective, of course, there's vulnerabilities in terms of contracting COVID-19, as well as the potential medical complications for someone who does have a substance use disorder. Okay, so what have we been noticing? One is Delta 8, right? Relatively new cannabinoid substance that seems to be hot off the press and in tobacco shops everywhere. And so this is something we've seen quite a bit of use among our young adults, particularly high schoolers. And while it's not technically legal for them to purchase it in a tobacco shop, you know, we know that it happens. And it's harder to detect on drug screens. And so we've certainly seen an increase in Delta 8 use as well as CBD use, which, you know, the CBD is there's a quick jump from the CBD to Delta 8 that we've been seeing. More substances that can be purchased over the counter in tobacco shops, and likewise as the kratom. We've seen increased kratom usage. And we've also seen an increase in fentanyl, both in terms of accessing opioids intentionally, but also through pressed Xanax pills on the street. Seen an increase in benzodiazepine use, and then those pressed Xanax pills being mixed with fentanyl or other types of medications that are being bought on the street being mixed with fentanyl. And we've had quite a number of instances where folks in our clinic have unfortunately used substances that were spiked with fentanyl and they did not know. And we've had instances where they've continued to use fentanyl as a result of the single exposure. We were also seeing an increase in over-the-counter substance use, and I hypothesize that part of this is the restricted access to some use early on in the pandemic. We've seen an increase in things like dextromethorphan, Benadryl abuse, and even like spices, things like nutmeg and other different substances that can be found in the home that can get teens high. And again, earlier on in the pandemic, just difficulties engaging in these alternative pro-social activities. It's such a challenge to try and find replacement activities and replacement behaviors for teens when they just simply weren't there. So it really created quite a bit of challenge in the overall treatment model of how we would approach comprehensive, multifaceted substance use treatment.
Yeah, Connor, as you were speaking, I was thinking about, like, in recent weeks, I can't put a timeline on it. Time is relative at the moment, but there has been an increase that we've seen teens who have primarily presented with cannabis use, and some of the cannabis has been laced with other things that have shown up on our UAs and has been a surprise for the youth and the families for a period of time. And I know we talked to some psychiatry folks over at Wake Med seeing the same thing. I don't know if that's still ongoing, but it was something we were observing on our team. So I want to move into, again, so my focus clinically in research and teaching is the interrelation of substance use and traumatic stress. And this is just one of the things that we focus on in the CAST program. We're a dual diagnostic program, and we know that comorbidity is common and pretty much the norm. So this is just one example of that. But if we can go to the next slide, Connor, when you're ready. I'm not going to spend a ton of time on the statistics here because you can just look at them and see trauma exposure associated with substance use. And it's been shown in the research and anecdotally time and time again. In fact, in our CAST program, we absolutely screen for, obviously, substance use, but we also screen for trauma, because in general, around half or more of teens with PTSD also experience problematic substance use. And these numbers are pretty striking. So if you look at these numbers, that exposure to interpersonal violence, 2 to 4 times the risk of lifetime substance use in a population of teens. And then just a little bit more evidence, but you can go in and dive in. The citations are here at the bottom, and there's much more evidence from where this comes from. The teens who binge drink are dependent on alcohol, 6 to 12 times more likely to have a history of physical abuse, 18 to 21 times more likely to have a history of sexual abuse. And again, these are just a few key points to show the relation between trauma and substance use. And that relation is reciprocal. We can go to the next one, Connor. Good timing. Yeah. So that reciprocal relation of trauma and substance use. Cravings can increase. This shouldn't be a surprise for all of you because you're all experts in the field, but cravings may increase when experienced trauma reminders. And again, once those trauma reminders are experienced, drug use could be a coping skill, not a healthy or effective one, and still a coping skill, right? So we try to give youth more coping skills to choose from, more healthy coping skills. So self-medicating to decrease the trauma reminders, or even avoidance of traumatic stress symptoms are some of the reasons that, that substance use is a problem. Substance use could also increase the risk for exposure to potentially traumatic events. So thinking about the reciprocity here, that cravings can increase when experiencing trauma reminders, and the risk for exposure for potentially traumatic events also increases when there's substance use. So I'm going to ask you all to put in the chat, what are some reasons you think that is, that substance use could increase risk for exposure to trauma? Because that reciprocity is key.
Here's one, Angela. Engaging in illegal activities to obtain substances.
Yeah. Yeah. Nicole, thank you. And Ed, thank you. Other people around you are abusing. Yeah. So yes, we can see that of engaging in illegal activities to obtain substances. where they get their drugs and who they're associated with, right? And thinking about like where you are and who you're with and substances and inhibition and being able to even think straight or notice safety concerns. So that and not from a victim blaming perspective, but more of what are the contributing factors is important. And we know that overall traumatic stress or PTSD may make it more difficult to stop using because trauma reminders have been shown to increase drug cravings in people with co-occurring trauma and substance use. So we can go to the next slide, Connor. I'm going to try to move through these as quickly as possible. When we look at substance use and trauma exposure, really thinking through this behavioral approach to understanding or doing a functional analysis. And this really reminds me for you DBTers that are with us today, it reminds me of a behavioral chain of really trying from a place of curiosity, not shame and blame. Let's understand the factors that are associated with substance use. Some of you may be familiar with this SORC model, and SORC stands for the stimuli or antecedent that precipitates the use. In this case, it would be trauma. O stands for the organismic or just variables that could either mediate or moderate the relation between trauma and substance use. What increases the chances, what makes the pathway to substance use even more clear. The response of interest is when do you use substances, and then the consequences with that. And we can go to the next slide as an example. So this is in one of the chapters, Dr. David Goldston, myself, Heather Payne-Seifert, and Shanna Cheek, we wrote a chapter on the interrelation between substance use and trauma. And you can see here, you may have to lean in, but you can see here an example of the SORC model, starting with the S on the slide being trauma exposure or trauma, even trauma reminders. And so what happens when that stimuli that precipitates the substance use, what happens? So they may experience hyperarousal or behavioral difficulties, mood dysregulation, intrusive thoughts, loss of control. So that could increase the chances of substance use. We also have things like distress tolerance skills, problem solving, decision making, proximities to peers who use substances, proximity to peers who may not be. So you can see where that could be, a protective or a risk factor of the use of substances. And then when substances are used, what happens? Of course, it decreases hyperarousal. It may increase positive mood. You may get short-term reduction of negative thoughts and traumatic stress symptoms. You may also get positive reinforcement from your peers. You also may get an exacerbation of long-term difficulties. You may be in riskier situations. So there's the negative consequences, and we have to also acknowledge the positive consequences that maintain that substance use and understand from a place of non-judgment to say, it makes sense why you used in survival. Like you're trying to cope with all of this stuff in that O column. Let's build that O column to have some positive coping and other alternatives to replace the likelihood of substance use. Okay. And this is where we get into really moving towards and promoting integrated interventions. A lot of times we'll see that youth may be referred elsewhere for substance use difficulties when being referred to mental health treatment. That, the presenting problem may be, we really need to get trauma treatment. This youth or young adult is experiencing traumatic stress symptoms, has been exposed to trauma. And then when there's substance use there's difficulty where sometimes the referral will happen where you need to go here to get your substance use under control. And then you can get the trauma treatment. And what we at CAST promote is those things are intertwined, right? Those things are very intertwined where if you start working on the substances, those traumatic stress symptoms might go up, right? So being able to integrate those things. And we'll talk about ADHD too. Jeff, thank you. There can be disagreement among providers about what could be targeted first as well. This is one example of the integrated intervention, TSTSA, You all can go in and take a look at it, but what I really love about it is that it's individualized, where it looks at the environment and survival skills for the children or the youth of, if they're in a high risk environment and there's no alternative coping, we start at a different spot in intervention. We really focus on stabilization before moving into skill building. And the same thing goes not just in trauma, but for youth and families with the presenting problem is ADHD, that if the coping skills are low, the environment may not be as supportive, we may focus on stabilization before getting to those core coping skills. So Ed, something that you were mentioning was, how do we know when to intervene? One of the things that we do is we screen for substance use. And there was a picture on the slide before of a fisherman throwing a net. And I am not a fishing person, but I know that if you cast the net wide, you're going to catch more fish, right? So screening is that. It's different than assessment. It's how can you do a broad brief, couple of questions to as many people as you can to capture those folks who may need a more comprehensive assessment. So just asking the questions about substance use as a part of like standardized protocol across the board for teenagers, we really want to promote. There's a lot of tools out there, screening tools that could be helpful. The Craft is one of them. And it's free if you ever want to use it. I really like it because it's how many questions? I mean, there's 3 questions and then follow up about risk. So are you using in the past 12 months? And then you can see the CRAFT is an acronym for, have you ever ridden in a car while using? Do you use it to relax, right? Do you use them when alone? Do you forget things? Do your family and friends ever tell you that you should cut down? Have you ever gotten in trouble? So those are those impairments that we look at to say, okay, this may be a time where intervention is needed or a more comprehensive assessment. So moving on to the more comprehensive assessment, we really focus in the CAS team and just overall to do a very comprehensive multimodal, multi-method, multi-reporter assessment. One of those techniques is those biological based tests. So we do urinalysis or UAs as a part of our program, but we really recommend using those in conjunction with other forms of assessment like self-report, interview data, questionnaires. And you can see on here one statistic as to why that 34% of teens self-reported substance use within a urine detection window and had a negative UA result. So that can be a piece. And we really do focus in on the UAs as one piece of data to track growth and improvement when we're providing treatment. Some considerations of that are cost. It can be expensive. Invasiveness, we do supervised UA. And then tampering, we've come across issues with that as well. And access. So if families have to drive somewhere to some lab to be able to provide their samples, that can be a barrier. There's also multi-scale questionnaires. These are more comprehensive. I have an example here for you all. The personal experiences inventory is one such that's made for adolescents. And they can take a good amount of time. So really, after you screen and you say, hey, this is actually a case where we need to do a comprehensive assessment, this can be really useful, these multi-scale questionnaires. And then next slide, Connor. Yes, Sarah, thank you for your question. We do. I mean, we talk about that as a part of our intake. We ask about caregiver or sibling substance use because the home environment is so key. And we really focus on a family approach of what does the substance use look like in the home as part of our interviews, which, oh, go ahead.
Oh, sorry. I was just going to jump in and say, Sarah, we'll talk a little bit more about our process a little bit later. Happy to answer more questions around this. With this type of thing, we usually ask the youth alone, as well as the caregivers alone, and talk about it sort of all together. So we're making sure that we're kind of creating space to talk about this in a way where hopefully we can get as much information and valid information as possible.
Mm-hmm. Yeah. And that leads to that structured and semi-structured interview, why that piece is so important. There's diagnostic interviews that exist. And so those traditional diagnostics interviews, they assess for a range of symptoms, substance use being part of them. Here's 2 examples, the skid and the disc. They're very structured. And then there's also substance use specific diagnostic interviews. You can see 2 down here, the ADI and the GAIN. We use a semi-structured approach. If we need to use a structured approach, we will. But again, we use the UAs, screeners, questionnaires, and part of the interviews for our evaluations, including assessing for family. And yeah, I think that I want to address everything in the chat because I really appreciate you all providing comments. And the ADHD piece is I think really important. Connor will go into that a bit more here, but I think part of it, yes, we do see an increase in ADHD, and we do see a whole lot of trauma in the CAS program. I would say both is some of the referrals that we get.
I want to talk more about the emphasis on the co-occurring presentations. And here are some common treatment modalities and approaches for treating substance use disorders in youth that are evidence-based and also allow for a focus on co-occurring treatment, as Angela said, or dual diagnosis. So peer support, we view that, some resources like NA or AA are really looking at developing those peer support programs for teens, which I will tell you is a challenge. That is a particular challenge for young people. And particularly, not just high schoolers, but our young adults too, where substance use, especially in collegiate settings, is more normalized, and how to develop those peer supports and get connected to programming that really emphasizes being able to live without substances and being able to live a happy, healthy life. And it is a challenge for young folks. But it is part of the programming that we try to support as well. Motivational enhancement. So this is your motivational interviewing, right? And working to resolve the ambivalence around substance use, working to help our patients and families understand how substance use impacts them as individuals, their lives, their loved ones in their lives, and really exploring and understanding their reasons for use, their reasons for not using. Generating and understanding their values and their goals, and how to align their life experiences, their choices, their engagement with others with the values that are important to them in their life. Cognitive behavioral relapse prevention. So a lot of this is quite behavioral. You see these next several treatment modalities here. So both CBT with relapse prevention focus and dialectical behavioral therapy skills development, these CBT and DBT approaches, these are embedded in our intensive outpatient programming. And these are focused on, from a CBT perspective, problem solving, understanding the mechanisms of use, understanding how to, from a behavioral approach, refusal skills, and being able to create replacement behaviors, create time and space, and limit access and opportunity to use, and restructure both thinking patterns, but importantly behaviors, which also includes restructuring the social supports. And that's where, as I should have said, these are listed separately, but boy, are they integrated in terms of a comprehensive treatment approach. For restructuring social supports, we want to be leaning into those peer supports as well. And motivational enhancement is just the cornerstone, right, of substance use treatment. And that's going to be part of each and every one of these. The DBT skills development, this is focused more so on the actual coping skills, behavioral skills that can be used as replacements, just distress tolerance, mindfulness, but also incorporating that problem-solving, interpersonal effectiveness approach. And Angela, please feel free to jump in at any point. I know you are one of our DBT gurus in our clinic, and a lot of times folks have come to us with these co-occurring problems, right? Whether it's ADHD, trauma, anxiety, depression. As folks get a little bit older, we've seen more bipolar disorder and psychosis. And the DBT has been so important to address not just substance use, but substance use plus, or what the conceptualization of depression or anxiety plus substance use. And it's been really helpful, I think, for our families and for parents to understand, as well as the adolescents and young adults, that these skills we're not just treating substance use disorder. We're trying to provide some skills that you can learn and develop that are applicable to a number of different factors of your life that can work together, collaborative, and really enhance the treatment approach for mental health and wellness as a whole.
And I would just add really quickly, Connor,
Please.
is that, when you're thinking of DBT, you can focus on many things. One of those things is impulse control. And so if you're thinking about some comorbid diagnoses being ADHD, trauma, that impulsivity to decrease the pain, or that stimulation seeking, you're giving them a lot of tools to use to notice when impulsivity is there, to be able to, we call it playing the tape of just take a beat, think about what could happen. And it takes a lot of skill development and time. But again, I think it's been really useful for our families.
Yeah, thank you for adding that, Angela. I see the question here. Do we use pharmacotherapy? Not currently. We are working on, we have a psychiatrist that's joining our weekly clinic meetings, and we are working on having them become more integrated into our clinic, where we might be able to do MAT and other psychopharm therapy. We are, of course, referring our patients directly to the DCEC or other community-based psychiatrists, where we can get them connected with med management, but we do not handle that within house. So contingency management, huge for adolescents, particularly, and young adults. And we're really working with families through the family therapy approach and helping parents understand how and where to set limits, but also how to create these contingencies so that it doesn't feel fully punitive, but that there is a way to earn the privileges that these teenagers have. A lot of times we're helping parents really, in some ways, kind of take back control and the power in their home, and really flip things upside down of the way they were, so that the teenagers are earning back those privileges in a way that's pro-social, and it's tied to the recovery targets. And this last box here, just the importance of integrated treatment for co-occurring problems. As we work with, whether it's in our intensive outpatient program or outpatient program, sometimes there are aspects of certain co-occurring conditions that need to be prioritized, and being able to be flexible to address the needs based on what the co-occurring problem is, while also continuing to integrate the treatment for substance use. This is the image from NIDA, just focusing on what integrative treatment approach looks like, starting with, as Angela talked about, the assessment, using evidence-based treatment, monitoring substance use through urine analysis, providing that ongoing case management, connection to recovery supports, and continuing care. It's not just the second bullet of evidence-based treatment, right? This is a comprehensive approach, and it should be touching really all aspects of a youth or young adult's life. So how to connect them, whether it's through academic or workplace services, mental health services, the medical services. We're working with families. We're working with youth that are juvenile justice involved. And of course, here there's the HIV/AIDS services. And so with young adults and adults and youth at being higher risk for sexually transmitted diseases and HIV, as a result of substance use being a risk factor, making sure that we're connecting them with supports to screen and service that. Okay, so I'm not gonna spend too much time. These are some busy slides here, but these are the principles of adolescent substance use disorder treatment. And I want to go through these and just talk a little bit about how we're integrating these into our clinic. So for starters, want to address substance use as soon as possible. And I was thinking of your question earlier. The second point speaks to this, is that even adolescents that may not have a substance use disorder with addiction resulting in intolerance and withdrawal symptoms, they can still benefit from intervention. And so a lot of times we will complete our evaluation and provide recommendations to families and help them understand where the risk may lie, not necessarily the current addiction, but what is this trajectory? What are the risk factors at play here? And what would the benefits be of trying to intervene early and correct course? Providing like primary care and pediatricians to providing the screenings to identify substance use early. The earlier teens are using substances, the more problematic it is later in life, the more likely they are to develop a substance use disorder, and the more likely they are to have co-occurring disorders. And so we want to be able to screen early and intervene as early as possible. I think there's this idea that some folks have that no one can change unless they're ready, unless they want to. And there's something to be said for that. And that's where the motivational interviewing comes into play. But also, especially for young folks, having the structure, both whether it be legal or family, around creating these contingencies and creating pressure where it needs to be placed can be important in getting teens connected and to sustain with treatment. So that's one of the main reasons why we take such a family focus, is because we want to make sure that we're providing these wraparound services, that it's not just the teen wanting to be in treatment and staying in treatment, it's also family, community-based supports that are helping them stay there as they need to. The treatment should be tailored to the unique needs of the adolescent, and it should focus on the whole person. And to me, this really speaks to the importance of integrating treatment and focusing on and screening for and assessing for co-occurring symptoms and disorders. All right. Sorry, I was just looking at the chat here. I'm going to just take a peek and then come back to the remaining principles. So Jeffrey, I appreciate your comments here. And I know that you all are doing amazing work in the community, and we refer to you all often, and I would love to hear from you, especially as we wrap up too, about some of the work that you all are doing as resources in the community. But you all do just really incredible work in supporting those college age youth as well too, or the folks that are in that transition age youth, young adults. So sorry, getting back to the principles here. The remaining principles, behavioral therapies are really effective. These contingency management, helping young folks develop these refusal skills, problem solving, as Angela was saying, that impulse control, playing the tape, and being able to really take a behavioral approach on minimizing the opportunity of use. Engaging families and communities, treating co-occurring conditions, screening. Angela talked quite a bit about the intersection of trauma and substance use. And then monitoring, both in a subjective and objective way, using the urine analysis, the drug screening, but also really working with parents to understand what are the signs of possible substance use, and how can you be, from a more subjective perspective, be monitoring this use. For example, financial spending, that's one thing that we talk with parents a lot about. Staying in treatment is just so important, and making sure that we're providing that continuity of care beyond the initial treatment of acute needs. We know that relapses happen. Relapse does not equal failure. It's an opportunity, if someone is continuing in treatment, to identify what where the concerns are, what the risks are, and address those and problem solve those. And lastly, testing and screening for sexually transmitted diseases due to the increased risk. Okay, so our approach to treatment and services. Just want to give a couple of shout outs here and just kind of contextualize our clinic. So David Goldston is our program director. Paul Nagy is our program clinical supervisor. And Paul Nagy was one of the co-founders of the CAS Clinic. He's been there from the beginning. And it's a privilege to have him continue supporting and consulting in our program. We're made up of psychologists like Angela and myself. We have social workers working with us, as well as psychology trainees. And the program's been around for 20 years, really applying those evidence-based treatments, and it's for youth ages 13 to 24, as well as their families. The scope of services that we provide are comprehensive evaluations, outpatient therapy, individual and family therapy, the intensive outpatient therapy program, school-mandated substance use treatment, also known as the DAC program, which is currently on pause. and as well as collaborating with community partners and university partners as well, including folks right here through Duke Do Well and Duke Reach at Duke University. So our approach is focused on, it does take a co-occurring emphasis. And things that we see most often: trauma, depression, anxiety, ADHD, psychosis, bipolar disorders, suicidality, and self-injury. It is not uncommon in any given intake to see 3 or 4 of these as part of the presenting problems and concerns. Speaking back to Jeffrey's point about cannabis use and psychosis, we have seen, at least I can say anecdotally, I've seen an increase of that, as well as bipolar disorder with psychotic symptoms. And it's really been quite remarkable. The strength of cannabis products these days is just off the charts. It's significantly stronger than the flower bud cannabis from years ago. And so we are seeing an increase in young adults presenting with psychotic symptoms that are alleviated when the cannabis disorder is addressed. We take a family focus, and take a family focus, and we're using many of the modalities that I reviewed previously. We are very, very collaborative. We have multiple team meetings a week, and part of that is because we're sharing patients across our team. So especially in our outpatient program, where we have individual and family therapy, a lot of times there'll be a clinician working with the family, maybe a clinician even working with the parents specifically, and one from those two working with the adolescent or young adult. And so we're really taking a team-based approach. We are focused on abstinence. Of course, there is room and space for harm reduction as well. For anyone under the age of 18, we really are focused on abstinence, and even over the age of 18, we're talking about the impairment and as well from a cognitive development perspective. We do not offer psychopharm at the moment, or detox services, or residential treatment, but we do help connect folks to those that would require that. I'm going to skip over this slide just in the interest of time. It covers much of what we talked about here around some of the principles of our recovery treatment targets. Our evaluation process, it's family and patient centered. We use these assessment methods that Angela was discussing earlier, and we are screening for things like trauma, depression, and anxiety. It includes a diagnostic interview, and that is both with the caregivers and with the identified patient. It does also include a urine analysis, and we are virtual at the moment, and our clinical services as well, our outpatient and our intensive outpatient programming is virtual. And really the goal of our evaluation is, to assess and learn what the presenting problems are, to provide an appropriate working diagnosis that we refine over time, to educate families and to educate the patients that come to our clinic, provide initial recommendations, and initiate treatment, and then a link to appropriate care. In terms of the outpatient treatment we provide, this tends to be for the mild to moderate substance use disorders that we see, with cannabis being the probably number one substance that we're seeing. Provide individual and family therapy, a lot of parent coaching around the contingency management, but also from a psychoeducational perspective, connecting these folks with the community. We do include urine drug screening as part of the outpatient program as well. And it continues to be abstinent focused, harm reduction as appropriate, and we're using those motivational enhancement techniques to move towards that abstinence focus as we can, of course, with that co-occurring treatment focus, and quite a bit of cross-disciplinary collaborations across community-based resources and other providers. So oftentimes with the outpatient, we have a lot of folks who come to us from they're referred by their primary mental health therapists, where substance use has now been identified as a primary need, and so we'll work together on these things. In the intensive outpatient program, this is an abstinence-based program. Now, we're not unrealistic. If you're coming in need of an intensive outpatient program, you're obviously not abstinent, right? Otherwise, we wouldn't have the program. So we're really working on this idea of making an effort for abstinence, of striving for abstinence. Sometimes when young adults or teens come to us and they are not ready to make that effort, we start with outpatient programming, if it's appropriate, to really work from a motivational enhancement approach to try and get that motivation or help them see where their motivations are for treatment, and then bring in connection to the IOP. Not appropriate, we might refer to a higher level of care. And this is more for our moderate to severe substance use disorders. And the IOP serves as a step down from residential treatment often, but it's also sometimes the last stop before residential treatment. And so we're really working hard to try and prevent from going into that next level of care, which can just be exceptionally costly for families and can have some pretty big consequences for families. It's disruptive to the home environment, and try our best to be able to prevent that if possible. We also approach this as sometimes through an assessment lens. Like, let's see what the response to an IOP level of care is. And if we can treat things through the IOP level, then fantastic. But it may serve, and we might do a 2-3 week trial to see if there does need to be an increased level of care. Family involvement is required. And so we have a multifamily group where parents are joining with their youth. And there's also family therapy that is part of this. So the overall structure of the program, it is 9 hours of therapy over 3 days, so 3 hours per day. Of each of those 3 days, there's group therapy that's focused on CBT and DBT informed skills and problem solving. There's the multifamily group where we're bringing all of the families together, and it's psychoeducational and process-based. And throughout each of the groups, there's a combination of skill development using the CBT and DBT skills, as well as opportunity to process and focus on application and celebrate successes and problem solve areas of challenge around skill use. Individual therapy is once per week. Family therapy is once per week, and I would caveat that to say at a minimum. And we're working to enhance these recovery behaviors. It's not just abstinence, but it's what else does the family and does that youth want to work on? What are their connections to the community? What are the pro-social activities and recovery-oriented relationships and supports in their lives, and working to develop those over time? And of course, the urine drug screens are part of this process to provide some of that objective information on the response to treatment. I'll just briefly cover the DAC program here. I know we're running out of time. We're almost done. This is on pause at the moment, but this is our psychoeducational program for students that have gotten in trouble at school for using drugs. And we provide an intake evaluation, and this is group-based, where there are 8 group meetings thereafter the intake. These are interactive psychoeducation modules focused on the neurobiological factors related to substance use, and really trying to develop a multifaceted understanding of substance use in developing brains in youth and young adults, and just helping them to see how it impacts their lives. I'm going to skip over this slide in the interest of time, and just want to make sure that you all have an opportunity to see how to reach out to us. So this is our CAS line phone number, as well as the website, which was also on one of the first slides Angela showed. And then I put my direct information here as well. So you are welcome to refer anyone to our program. You can call our CAS line number. You can reach out to me directly as well. So this is my direct email, as well as my confidential and direct phone number that you're welcome to leave a message. And we do our best to get back to folks within 1 to 2 days. We are currently on a wait list. It's not particularly long, but we do have a wait list. So I do want to provide that disclaimer, but we're working to get through it as quickly as we can. Thank you all so much for your attention and time. We have some acknowledgements here of our partners and folks that contributed to our presentation. And I know we just have a few minutes for questions.
Well, thank you very much. That was very enlightening. It's very important work that you're doing, and it looks quite comprehensive. So before we get to some questions, I just wanted to acknowledge and welcome the folks, Rick Coyle and Jenny Park from the Center for the Study of Adolescent Risk and Resilience, and hopefully we'll have further collaborations next semester as well. So now we do have a few minutes for questions, and if anyone has any, I have a couple myself, but I don't want to dominate. So if anyone just wants to unmute and speak up, that's fine. If not, I have questions.
I have one quick question.
Yes, please.
Well, thank you both for the great presentation. probably it's difficult to measure in this subpopulation, but what is the success rate of using these common treatment modalities? What is the success rate?
I wish it was an easier question to answer. It just has varied so much, and especially as we've migrated into the virtual space, we've seen a mix of response to the different levels of care. I would say currently right now, boy, it's been a rocky road with our IOP program, and we have fabulous group cohesion right now with some really incredible response. We're in the process of focusing more on progress monitoring and being able to garner data to really speak to that question a little bit more. But right now, I'd say it really is a case-by-case basis. But certainly when folks do get connected with our program, we're seeing benefit in terms of being able to identify and escalate treatment if needed, or have positive response, particularly in the outpatient program where escalation of treatment is less common. We are seeing positive response with a great deal of frequency. I don't have specific data for you though.
Okay, thank you.
I have one. Speaking of the virtual space, we've been kind of forced into this with the pandemic and all. Can we kind of take advantage of that and some steps forward? The younger you are, the more attuned you are to smartphones and social media and so forth. And so is some of your efforts kind of going in that direction to meet them where they are in terms of presence in social media and use of smartphones to kind of have a continuing resource for them to kind of avoid relapse, that sort of thing?
I certainly want it to. And I think the friction point there, Ed, is that the smartphone use is linked to social media, which is linked to access to substances. And I should say Snapchat is one of the biggest that we neglected to mention in our presentation. That is one of the biggest, not just triggering spaces for our teens, because drug dealers will put and post out when they have supply, and they do these blasts through Snapchat. And so they're from a contingency management perspective, the phone is a factor, and then from a triggering and access perspective, the phone and social media is a factor. But that doesn't mean that it's also not an important resource to be able to meet them where they're at and try and implement some more of the approaches directly to the media. We are in the process of trying to expand that and move a lot of our work into the virtual space through things like Qualtrics, where we can do progress monitoring and reports of skill use.
One of the things we actually celebrate is when in groups, when our youth decide to block certain people on their social media, because even memories of pictures will come up, which will increase urges to use. But we've seen people use Snapchat and other social media devices to even get drugs delivered to their home during the pandemic.
Yeah.
So it's been tricky.
Yeah, I can see that. Yeah. Well, thank you so much for your excellent presentation, and hope to revisit some of these issues as we proceed through the next semester. And please keep up the good work, and I look forward to hearing from you as things progress. So I just wanted to mention this is the last presentation of this semester. I wish everyone a happy holidays and a happy new year. And we're going to reconvene on January 19th with Linda Perino. We'll have a new link that'll be in the on the website, and also sent out over our listserv. So if anybody wants to be added to the list, please email me. I think I've just received one just now. So thank you, and I'll see you, and have a great rest of the afternoon. Okay. Bye.
Thank you all.
Thank you all.
Bye.